Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome students in our surgery lecture number 10, that is the portal hypertension. In this lecture we will see the etiology, pre-hepatic causes, hepatic causes and post-hepatic causes of the portal hypertension, collateral circulations, investigations, measurement of the portal venous pressure, management and emergency operations in portal hypertension, shunt operations like porta-caval, lino-renal shunt, mesenterocaval shunt operation and complications of the shunt operation. Let's start. Portal hypertension. Portal hypertension is an increase in portal vein pressure above the normal level of 5 to 10 mm of Hg. Normal direct portal pressure is 15 mm of Hg or even more. Due to obstruction somewhere in the portal vein or in its system, in its tributaries, pre-hepatic or portal venules or sinusoids in the liver, hepatic or in the hepatic veins draining into the inferior vena cava, that is the post-hepatic. Now the etiology. Pre-hepatic causes constitutes about 20%, hepatic causes constitutes 80% and post-hepatic causes rare and occasionally seen. Now pre-hepatic causes. Congenital atresia or hypoplasia as an extension of the obliterative process of the umbilical vein and ductus venosus. Another cause is Cavernomatous transformation of the portal vein represents thrombosis and recanalisation within the vessels. On your screen you can see the diagram of the image of the portal hypertension. It refers to an elevated pressure in the portal vein due to the cirrhosis of the liver. Another image showing the portal venous system, how the portal vein is collected the blood from the large intestine, small intestine through the mesenteric veins and from the stomach and spleen and goes into the liver. Third pre-hepatic cause are the most common in this group is portal vein thrombosis. Fourth is trauma and extrinsic compression caused by adhesions, tumors pressing on the portal vein. And sixth cause is isolated splenic vein thrombosis may be caused by alcoholic pancreatitis. Now the causes number 2, hepatic causes, nutritional cirrhosis, most common cause, post-necrotic cirrhosis, biliary cirrhosis, hemochromatosis, Wilson's disease, congenital hepatic fibrosis, infiltrative lesions, schistosomiasis, fibrosis of the terminal portal venous radicals. Here is another image of causes portal hypertension. Post-hepatic causes, hepatic causes are Budd-Chiari syndrome, obstructive of hepatic veins, failure of the right side of the heart, maybe tricuspid valvular incompetence and constructive pericarditis. Collateral circulation. Now the collateral circulation of the portal venous systems. When there is obstruction to the portal veins, nature tries to reduce the portal pressure by diverting blood from the portal system to systemic through a few known collaterals. Like first, vein obstruction is in pre-hepatic, then the collaterals between portal vein and distal to obstruction and the portal vein proximal to the obstruction enlarge. Accessory veins of Sape, the hepatic and hepatorenal vein and veins of suspensory ligament become enlarged. Second, vein obstruction is in intrahepatic. Then the collaterals between portal and systemic system becomes dilated and transfer the blood from the high pressure to the low pressure systemic venous pressure. These collaterals are collaterals around the lower end of the esophagus, that is the esophageal pharynx, collaterals around the lower third of and the canal between the superior hemorrhoidal veins causes hemorrhoids. And if the collaterals around the umbilicus between the paraumbilical veins which accompany the ligament teres hepatis and the superficial veins of the abdomen wall which drains into the superior and inferior epigastric veins, that is the caput medici. Now here is the image of the portal hypertension circles, portal venous system showing the collection of the blood and the blood circulations. Now the special investigations: blood, anemia due to bleeding and hemolysis and nutritional deficiency, leukopenia and thrombocytopenia due to splenomegaly. Coagulation defects are the common and mostly due to thrombocytopenia. Liver function test disturbances indicated by the various tests. Endoscopy represents the most reliable single technique. It shows esophageal pharynx and bleeding point. Fiber optic instruments to visualize the inside of the esophagus and stomach. Varices are seen as dilated longitudinal veins running a zigzag course. Next indication is radiology, upper GI barium. Series may demonstrate esophageal varices as a filling defect at the lower end of the esophagus. Less accurate in the diagnosis of gastric varices. Liver angiography. Two main advantages of liver angiography is: one is the measurement of the portal pressure, second is the visualization of the abnormal venous anatomy in case of portal hypertension. Now here is the image showing the functional component and the structural component of the portal hypertension, how the portal hypertension affected on the another organs of the body is clearly showing in this diagram. Now the measurement of the portal venous pressure. This can be performed by the direct measurement through transhepatic portography, umbilical vein catheterization and splenoportography. May also be performed by indirect method, wedging a catheter in peripheral hepatic vein. Under local anesthesia, antecubital vein cardiac catheter is passed through the right atrium and inferior vena cava. Under the radiographic controls, the tip is then passed through the hepatic vein until a peripheral radical is occluded. Tip of the catheter should be peripheral position and pressure recording are then taken. This is the method of the measurement of the portal venous pressure. Portal venography or portography often performed by splenoportography. Now the management of portal hypertension. When patient comes with acute variceal bleeding, management in 3 stages: resuscitation, diagnosis and specific. First, resuscitation. Blood volume should be maintained by the blood transfusion. If there is a massive blood loss, then blood transfusion should be done. Coagulation abnormalities require fresh frozen platelets. Saline should be avoided because of ascites. There is a liver cirrhosis and portal hypertension, so there is a high risk of the IV fluids, so saline should be avoided. Only blood transfusion should be done. TPR, BP, CVP, central venous pressure and urine output chart should be monitored. Sedation is to be given. Rapid cleaning of the blood from the bowel by mild purgatives and enema will reduce the ammonia load and hence encephalopathy. Cimetidine by gastric acid secretion. Ascites, sodium intake should be minimized. Spironolactone, aldactones should be used, which are the potassium sparing agent. Paracentesis is required to reduce the intra-abdominal pressure. Diagnosis: endoscopy is main diagnosis tool for this esophageal varices. Now the specific treatment: vasopressin, pitocin, a potent vasoconstrictor used to control the variceal bleeding by splanchnic vasoconstriction. Pitocin has a short half-life of 10 to 15 minutes only. Endoscopic variceal sclerosis. This is the revolutionize the treatment to variceal hemorrhage. Definitely decrease the mortality rate. Paravaricial and intravaricial injections of STD, sodium tetradecyl, through the endoscopic injection is to be given in the varices. In acute bleeding, intravaricial is preferred, but to stop recurrence of bleeding, paravaricial injection is preferred. So paravaricial injection is preferred. And in the specific treatment, there is a balloon tamponade also, temporary method to control the acute bleeding. If the endoscopically method have failed to control it, then the sex taken, black moret tube, gastric balloon 300 ml of air and esophageal balloon of 45 mm of Hg of pressure is inflated in the lower third of the esophagus. Due to this pressure, the bleeding points or the rupture vein is stopped. Fourth is the transhepatic visceral embolization. Choice of operation: here is the shunt operation usually done in the portal hypertension and liver cirrhosis. Emergency operations like only temporary measures designed to arrest the bleeding. Transthoracic esophagectomy. If there is a massive bleeding and bleeding is not stopped, then the transthoracic esophagectomy, 8 and 9 rib incision in the left lateral position. Borima Krell operation, column of varices sutured by the vehicle longitudinally. Stapler of esophageal transaction and reanastomosis of the esophagus. Melanis-Walker operation, mucous and the submucous coats of the esophagus are transected and then resutured to interrupt the communication between the portal and the systemic vein. Tanner's operation for bleeding varices in stomach. Stomach is transected 2 inches below the cardia and all its veins have been divided and ligatured in immediately. Reanastomosis. These are the emergency operations in severe esophageal varices. Now the diagram showing the insertion of the gun into the lower esophagus via a small anterior gastrotomy. The anterior vagus is protected in a sling. Second diagram showing a ligature is placed around the esophagus and the gap between the conical head and cylindrical body widened. Third diagram shows the ligature is tightened about the 2 cm above the cardia and the flange of the full thickness of esophageal wall invaginated between the 2 parts of the gun. Another diagram is the endoscopic sclerotherapy. CM means the circular muscle, MM means the muscularis mucosae, and the OV means the esophageal varices. Diagram first showing the paravarical injection is shown. Note that the injection is made by the side of the varices so that surrounding sclerosis causes the constriction of the varices. Another diagram, second diagram showing the intravarical injection is being shown, and injection is made inside the varices, means inside the vein, so that the intravarical thrombosis occurs and leading to cure the condition of the massive blood loss. Now sixth is the emergency operation is the esophageal transaction with paraesophageal devascularization. Esophageal transaction, splenectomy, paraesophageal and gastric devascularization, selective vagotomy, pyloroplasty advocated by the Segura and Futagua, endoscopic bending of the esophageal varices, lower 1/3 of the esophagus, endoscopic sclerotherapy, that is the para, lateral and intra-acute variceal bleeding. Now the shunt operation for the portal hypertensions are, there are 3 types. Porta caval means portal vein and vena cava, linorenal means the splenic vein and the renal vein, and mesenterico caval means the mesenteric vein to direct inferior vena cava. First is the porta caval, first choice of the shunt operation in the portal hypertension in the Pocher's manual to explore the IVC. Porta hepatis and IVC end to side anastomosis as well as side to side anastomosis is also possible. And second operation, shunt operation, is the linorenal shunt operation, only performed when there is a thrombosis affecting the portal vein. Thoracoabdominal incision is to be taken, and the splenectomy is also done in the linorenal shunt operation. Mesenterico caval shunt operation is the third shunt operation in the portal hypertension. This is the third choice of operation, only used when above operation are not possible, then this mesenterico caval shunt operation should be performed. Here is the images showing the porta caval operations, shunt operations, and this second image showing the linorenal shunt operation. The renal vein is directly into side anastomose with the renal vein, and third image showing the portal and inferior vena cava shunt operation with the graft. Here is the image showing the side to side porta caval anastomosis, and second showing the end to side porta caval anastomosis. This image shows end to side splenorenal anastomosis after splenectomy, and this diagram shows the mesenterico caval shunt, that is the diagram A shows end to end anastomosis and B shows side to end anastomosis, side to side anastomosis, superior mesenteric vein, SV means the splenic vein, PV means the portal vein, and SMV means the superior mesenteric vein. Now the complications of the shunt operations, there are 2 types, early complications and late complications. Early complications, hemorrhage from the suture line, occlusion of the anastomosis by thrombosis, hepatic coma following liver failure, and second is the late complication, that is the portosystemic encephalopathy. Normally toxic products of the protein break down, mainly ammonia in liver. Detoxicated in shunt operation, toxic products get direct access into the systemic circulation and reach central nervous system, brain encephalopathy, oftenly precipitate after large protein meal or after upper GI bleeding. Clinical features: disorientation, rigidity of limbs, flapping tremors, outstretched hands, and deep coma, slurring of speech. Treatment: restriction of protein diet, magnesium sulfate purgation, enema, removal of the blood from the gut, electrolytes balancing, and vitamin supply. These are the treatment of line. Friends, you can watch a good videos and another images to clear your concepts from the YouTube. And here is the end of our portal hypertension lecture number 10. Thank you.